Bueno, amigos de Sepa 2026, estamos en el Espacio INTEGRA aquí en Granada, en colaboración con Perio MX, y el día de hoy me encuentro muy contento porque me encuentro con un gran mentor, un gran amigo, un profesor, una persona que seguimos mucho en todo el mundo, el doctor Francesco Cairo, the only and the unique Francesco Cairo. Thank you so much.
Thank you very much.
So, right now we have the mucogingival conditions, gingival recessions. I don't know, it's a hype in the social media channel. It's a new era about mucogingival therapy. How do you feel in this new era? Because a lot of clinicians are uploading photos about treatments. You are cited there. The new classification or the actual classifications about you. What's your feedback about it?
Well, my perception is quite strange, but also enthusiastic. Because I started in the late 90s as a Professor Gianpi Pini Prato pupil, I would say. I started to study mucogingival surgery. This was the name at the time. And at the time it was a niche argument. It was very interesting for very few periodontists. What we explored was an incredible number of trials testing different techniques, and the outcomes now are really predictable. And this means that the argument became a treasure for all periodontists. It's quite predictable to cover a root today, and it's it's highly satisfactory for dentists and for patients to see the outcome of root coverage. So basically, I think that this large interest on social media among professionists or among periodontists is based to the fact that the outcomes of root coverage are really concrete, very easy to be perceived by patients, much more than treatment of periodontitis. That is for sure the most important thing that we can do, but it's quite easy to understand or to detect the outcome of treatment after root coverage, and are highly satisfactory for patients that think to be very young or younger than the baseline after root coverage.
And right now the communication with the patients, because, well, I don't know, you are very famous, and maybe the patients looking for you about gingival recessions, no? But right now, is a lot of patients recognize gingival recessions.
Yeah.
No? Maybe recognize gingival recessions before a periodontal pocket, because periodontal pocket is a very silent condition and a part of disease. How do you feel comfortable about that or not? Because, well, we have, in one way, periodontitis, that is a very difficult disease in the late stages, and we have gingival recessions. What do you prefer in your practice? A patient with Cairo type 3 or a periodontitis stage 4?
Well, basically, I'd like to start this very nice question, to start to replay, starting to the fact that I'm a proud university professor in Florence. I guide an EFP, specialty school, so every single day of my life work with Perio students and postgraduate Perio students. And they clearly demonstrate a lot of passion in trying to perform perioplastic surgery. Mm-hmm. But what I deeply support is Perio is treatment of periodontitis. Perio is non-surgical treatment and then flap surgery. So it's very, very important to educate postgraduate students to treat periodontitis, because we know very well that it's a worldwide problem. On the other hand, I think that we have today the knowledge and the surgical skill to start for treating very predictably also recession type 2. We published a 10-year follow-up of randomized clinical trials demonstrated that full root coverage is possible also in recession type 2 according to the new classification system. And this was, when we published the first paper, it was around 15 years ago. something as a revolution in perioplastic surgery because according to Miller paradigm and according to the ancient technique, there was no possibility for full root coverage at Miller class 3. So basically now we are starting to try to publish something of predictable also for rejection type 3. We are starting to use, for example, Tanek technique for rebuilding papilla. I'm publishing new data on it. But so what is very, very impressive is the enthusiasm and the growing knowledge that every year we have. And this means that today is absolutely very important to treat the periodontitis, to save it. But on the other hand, we can improve also aesthetics in patients that were treated for periodontitis. And this, I mean, is an incredible new achievement in the new millennium.
Yeah. So in that way, tell us about the impact of the Sepa CDP mucogingival consensus. What's your opinion about it?
Well, I'm very enthusiastic because I was the president of the CDP, and so I prepared the consensus along with my good friend José Nart, that was the president of Sepa, and we deeply worked with the EFP group, with Tony Sculian, and with the whole team of the EFP, and we had a beautiful consensus in Florence last year in January. Well, I think that was something of very impressive. It's quite difficult for me to separate, the objective mind from the passion, but basically, I think it was very impressive to cluster in Firenze the most important expert all over the world discussing about literature in Perio and basically try to understand what means today performance and efficacy of root coverage procedure along with patient-related outcomes and also standardized approach for aesthetic evaluation. So I think that this focused workshop was, to me, something of revolution because probably was the first time where EFP cooperated with two societies, but also means something of very important according to what Professor Niedelman stated. It is the fact that for the first time we try to merge in a single consensus the evidence from the literature, the skill of the operator. This is another very important issue along with patient perception. So this is very important. I think that this kind of approach may represent a good example in the future to try to rebuild a new consensus merging this factor.
Well, we are talking to all the Sepa community and from Latin America community. You're a professor, I'm a professor. You are an inspiration for a lot of students.
Thank you.
Well, your mentor was Pini Prato.
Yes.
And when starts your, I don't know, your creativity or the possibility to change the classification? Because we are studying 1985 classification.
Yeah.
And then, well, we are studying Cairo classification. So can you imagine that when you're studying?
Yeah, I can share a secret if you want. But basically, I spent a lot of time in our Perio school with Professor Pina. At the time, I was an assistant of Professor Pina. I was very enthusiastic. I spent a lot of time to do surgeries, to try to push the clinical research. And we spent a lot of time together with Professor Pini trying to discuss the limits of Miller classification. Yeah. And what we basically, and I think that, I think that Preston Miller is a giant in the literature. Claro, yeah. And he clearly demonstrated how it's important to have a classification, and he's basically, firstly, try to set a prognosis of treatment. And what I argued was that Miller, at the time, was almost concentrated among the prognosis of the free gingival graft. Yeah. So this is very important for understanding, the beginnings of my classification. And the secret is that I'm thinking a lot to try to overcome the limits of Miller classification. that were not the limits by themselves, but were limits related to the fact that he was thinking to the free gingival graft. So I tried to work on an idea that was able to cluster the new surgical technique, mainly looking at the interproximal area. And I remember very well, a very nice evening with some good friends, drinking some wines. I'm not joking, I'm serious. And at the end of the night I say, okay, I think to have a good idea. These good friends are also some colleagues in the Perio department in Florence.
In what year, sorry, in what year happened that?
Well, we were the subsequent morning in the Perio department. The name is Sandro Cincinelli and Jana Mervert, that are some co-workers of the original paper, and we started to test the real ability of this classification. So basically, what I think is very important to study, but it is very, very important to save some good space with the good people in your life to thinking that something that could be interesting.
Well, and the last question is a question that is, in Mexico, we say that it's a very chilly question. It's a picante question.
But I'm from the south of Italy, so I know very well what means peperoncino.
About calf versus tunnel. Well, Sepa is, I don't know, in Spain is so popular tunnel, and we have a lot of knowledge about calf, about Italian school. So I don't know, tunnel is, in my hands, it's so complicated that we have to spend a lot of time to make it. So calf is a very comprehensive technique. So it could be possible that maybe calf is the gold standard for root coverage right now?
Yes, absolutely. The literature say yes, but my suggestion is to try to go, to look at the horizon. And I think that as a clinical researcher and as a clinician too, I love tunnel, even if I think
you love tunnel?
Yes,
Okay.
I love tunnel too. And I think that it's very useful in a clinical practice. And I think that it's very important for a young periodontist to learn both coronary advanced flap and tunneling procedure, because they show totally different indications. Basing on the evidence and according to our consensus, when you are going to treat gingival recession, the upper arch, the primary option is the coronary advanced flap, because it's the most supported technique. But basically, the advantages of the coronary advanced flap is the possibility to really select the final position of the gingival margin without tension. And this is typical of the coronary advanced flap. And this is an incredible support for any procedure using, for example, connective tissue graft that at the end of the story want to select the final position of the gingival margin. On the other hand, I think that tunneling procedure is very, very important and very, very effective to increase gingival phenotype, especially in the lower jaw, to achieve root coverage with different approach, meaning some exposure of the connective tissue according to the beautiful original Zabaleghi technique, or according to lateral closed procedure, or trying to move the tunnel in a coronary direction according to the Zur technique, for example. But basically, the tunnel offers some advantages. For example, to try to insert some connective tissue graft under the interdental papilla, and we are probably at the beginnings of new papers that are trying to, to identify in the next 10 years what is going at the horizon. So basically, there is no real battle. There is the scalability, the knowledge, and the capacity to understand in the clinical scenario what is the best.
Yeah. So, well, we can talk with you hours. Thank you so much.
My pleasure.
We are very happy with you in this Espacio INTEGRA. Thank you from Sepa, gracias a Sepa. Dr. Francesco Cairo, thank you so much. It's your home, Sepa.
Thank you.
See you next time.
See you.
See you.